the value of what a pharmacist brings to the healthcare system has not been highlighted correctly, has not been brought to the forefront. And I think part of the reason that's why we're going to pivot to the KDA bill, which we support as pharmacists, because it's bringing standards back. We're trying to get standards. The KDA divides the product from the practice, in which case you don't have the products or the commodities, which say HPTs, pulling back the profession, or the profession pulling back the HPTs. They go separately and they grow according to their needs of the various things. And I think that is a key part. Anybody, and this is now almost a declaration, anybody who enters a healthcare system, including your dog, has to go through a pharmacy or use a pharmacy-related product to move from why they got into the care to when they get well. And the drug, whether it is just for testing, whether it's actually a drug that you're going to take home, whether it is an NCD, you have to use those drugs. And who's a drug expert? And I introduce myself as a drug dealer more often than not, because that's all we do. We deal, we study, we learn, we are exposed to drugs and how drugs work. Why then is it that value is not brought in? In the US, they say the economic impact of wrong medications, not wrong medications, between 20 and 40 billion a year. The economic impact. Dollars. If you do some quick math, Kenya will then be around $4 to $5 billion in terms of what? Economic impact of wrong medications. That is almost the same amount what we use in all healthcare. Does it mean if we manage our meds correctly in this country, we will have economic output enough to provide healthcare for free without increasing taxes? And that is what the enormity of using the drug correctly is. It's so important that even when you go to the pharmacist, you're tired, please ask the questions. Ask questions, enough questions, to understand that what you're carrying, what it's going to do, what are the side effects. If the side effects come, what do you do with those side effects? What shouldn't you eat? What time should you take it? How should you take it? Those are details. And a good pharmacist will do that very quickly and give you the information. The idea is you make sure it's 4th grade level, so that anybody, and that's why I used to ask the question to gauge the words you're using to tell me I shouldn't give you 4th grade, maybe I should give you 12th grade knowledge to how to deal with that.
So should you have a pharmacist after the doctor before you go to the dispensing place?
Yes. Actually, one of the things we were talking about at PSK is having a family pharmacist, just like you have a family physician. A person who understands all the meds you're taking, how you're taking them. If you want something over the counter, does it interact with the current NCD medications? And that's the next thing, actually.
But we don't have family physicians.
I'm not even talking about the one you go to see on a Saturday morning.
Correct.
I'm talking about in the clinic.
Yes.
In the hospital. Should you not, when you leave the doctor who said these are the lab results, before you go to the counter where they dispense, because if a prescription has been written and I know what's in the thing, can dispense. Anybody can dispense.
Yes, that's true.
But from what you're saying now, shouldn't you then go see a pharmacist before you go to the dispensing counter?
So I would suggest, and not because I'm a pharmacist, that would save the healthcare system a lot. Because then you don't take things away that you should not be taking. The number of people who are on dialysis in this country, the number of people who are on who have liver failure in this country, yes, alcohol is an issue, but the medications that are a part of that. The number of medications that are being given that are actually interacting with other medications you're taking, the harm, the deaths that have come because of those things, they are there. We don't keep very good records of that, and we're going to move that. We're going to move towards that. Part of the reason why KDA is a very good bill is that it raises those standards. It raises standards, makes sure that the competencies and the technical competencies of whoever is participating is right. And the bill has a lot of reference to WHO standards, which we talk about personnel, talks about training, talks about who should do what. And it's very important. I personally think, and this is my personal opinion, that the KDA bill is a patriotic bill. And you'll ask why. Because if we put the pharma industry where it should be, it will create jobs. We'll be able to sell, because then the competencies of what we are selling out, the pharma, the foreign currency that will come in from us selling medications would increase. But we have to make sure we don't shoot ourselves in the foot. We have to make sure that we have the right technical people doing the right technical things. Just like what, when you come from a physician, you see a pharmacist who guides you, then whoever dispense can dispense. Could be another pharmacist dispensing, but now it's gone through the check that is necessary. I will bet you the amount, they say, oh, it's expensive to hire a pharmacist. The amount of what we'll save as a country, the pain and everything else, would be enormous.
Where do farm techs fit in all this?
So, it's political.
Those are two very huge
There are
sides.
there are two issues here. Remember, I alluded earlier on that the number of pharmacists we were educating, training, was a little less than what the market needed.
Yeah.
Yes.
So then the whole history of why technicians were the clinical officers, technicians. That's a whole history, a geopolitical issue that why it started and where it started. As a result of not being we did not think through the whole thing, how it's going to end. We didn't think about the end in sight. And as a result now, we've come to a place where technologists actually do 3 years of school. Pharmacists do 6. So there's a gap there of 3 years. And that 3 years is what I was talking about, exposure. I talked about the knowledge base. And when you have a knowledge base and the exposure, then even calling an audible, changing something, you understand what you're changing. And that wealth of information translates into safety on the patient side.
But do they have the basic?
They do.
They do have the basic.
Correct.
And the basic here, would that basic go to the extent of sitting down with the patient? If we said that we go this route and say, from the doctor or clinician, you will go through somebody who understands pharmacy. Can that person be a farm tech?
So, I personally would say no. I personally would
Why?
suggest, because just what I just said, the knowledge base, the exposure, the knowledge base, because 3 years extra of school.
Where would you place a farm tech in this chain?
I think they're dispensing. Dispensing is an excellent place. And then if you look at the international standards, and you see, and that's why the KDA bill is alluding to the WHO standards a lot and international standards, is exactly what I'm saying. The international standards, I remember one of the jurisdictions I used to work at, the technician who was there could not even put medication in a bag.
Why?
Because my license was on the line and I wanted to make sure that all the meds that go into that bag belong to that patient. And if they don't and they go harm that patient or the wrong medications, it's me. So I only, if I trusted you enough, I could allow you to do it. But I would put all my medications in the bag myself. So
because it's you who has the license.
It's me yes, it's me who has the license.
Let me ask this question differently. You look at the different cadres of healthcare professionals. Okay, we're referring to the farm tech. I'm looking at clinicians and I'm looking at nurses. Different cadre. Not lower, not higher, just a different cadre. I'm looking at clinical officers. Different. And many others. Now, for these cadres to exist, there must be a good reason. There's a role they're supposed to play. So what is the role of the farm tech?
So I don't know whether I can answer that really well, because there was when the whole farm tech of now farms technologists was when that role was initially developed. What was behind the thought process, I cannot allude to because I don't understand.
Can I assist you?
Yes.
Because if I look at how we categorize our healthcare system, it's in levels.
Yes.
So you will find a certain healthcare professional at a certain level.
Yeah.
And until you get to a point where at that health facility, you then get to a doctor. You'll get a nurse. You'll get a clinical officer. Then at a certain level, you get to a doctor. Okay? And with a doctor comes facilities. You have a lab. and then you have a certain category of lab as you keep moving up. So I am taking the view that it was with that same thinking that the position of the lab tech was.
Okay, I mean,
Yes.
I'm also seeing something maybe, and
Yes.
you could correct me. The entry level requirements academically, right? So at a certain point in time, everybody who was getting the A's wanted to be doctor. And then they want to proceed on to become whatever, the cardiologist and everything else.
Yes.
And not many wanted to do pharmacy.
Yes.
And now we have a shortage of pharmacists. And those that are qualifying for this particular profession are not preferring to go into pharmacy. But we must have people who are doing this job. So you go into a lower entry level requirement, and now you take it to a diploma level, and you have the farm techs coming in and playing a certain role in this value chain.
Eric,
How far am I
I
from the
don't
truth?
I don't know what's happening now,
Eh.
but you've taken my mind back to when we joined university. Pharmacists and doctors had similar qualifications.
Yes.
It was not, you could be either.
Yes.
It wasn't that
Yes.
you did. It was,
That's what I'm saying.
yes.
It was the A. For you to be a pharmacy, you've got
A.
to score
Yes,
A.
you had to.
But then, those that are scoring A's are not choosing
Pharmacy.
pharmacy.
Oh, no, actually, it's interesting that you say that.
Is that
right
not-
now we have a glut. We have more
Now more
pharmacists
and
than we
more.
can- we have
Now more and more
pharmacists.
choosing.
Yes, we have more pharmacists than we have spots for them.
Yeah.
That's one. Number two is the same issue that we have with clinical officers and physicians. Same conditions. Well, when we started, pharmacy was being taught in one school, which is University of Nairobi, and they used to take about 20 to 30 people, right? That does not that is not going to be enough
Yeah.
for a country like ours.
Yeah.
And that is and the thing is, so then as a result, it will now reduce to dispensing, because that's what you can do quickly. Okay? And I stand to be corrected on that, but that's just logically. However, when we got to where we are right now, cost of care the way it is, unless we address the way we use our medications, we are not going to cut it. Because think about what we're having about the antibiotic resistance. We're having patients who are actually losing their lives because they're using the wrong medications.
Yeah.
We are coming to cancer, that there's very toxic medications. When you're a patient receiving chemotherapy, this is another function for a pharmacist. When you go home, your family and loved ones have to handle you in a particular way. Your fecal matter, your urine, all those things, your saliva sometimes is actually toxic. But we don't know how to deal that. And that's a pharmacist's job, who should come in and say, here is what you can do here. And that is for safety for the public.
Yeah.
So when we have a pharmacist really installed properly to work the top of their license,
Yeah.
it's just like the aviation field. If you get them to understand drugs, and they understand the drugs, to be able to explain how drugs should be used, safest way possible, we change how healthcare works, and we reduce the cost in healthcare.
So if understanding this whole, and I think it's an end-to-end thing, understanding all of this, then we also then want to ask then who bears the responsibility to ensuring that that particular peg is placed in this process. Who should? Because I don't think doctors necessarily want to moonlight as pharmacists. You know, they do their job in diagnosis.
Correct.
That's why they hand it over to somebody else. But I think here we're also saying that there's a certain level of, I don't even know if it's understanding or it's just like, look, I've done my part until here. Let somebody else take over, right? But it needs to be an inclusive thing.
Correct.
That is what we are saying.
Correct.
So who's responsible? I don't see pharmacists coming in and, poking themselves and say, you must include me. So it seems almost as though it must be an invitation of necessity.
Yes, and there's a few places. I'm just going to, there are many, but I'm just going to name one. Moi Rifaro, there's Dr. Keegan there, who's been able to set up a very good system where there are some cases, actually there's even a pharmacist in Kembu, there are some cases the doctors will not round without that pharmacist being there. Without the pharmacist input, they will not move because the pharmacist will come and do, will do the drug part.
Because the doctor has insisted.
Because the doctor has actually understood the value.
Right, okay.
So the thing is, they've gotten exposed to the value, and once they get to understand, wait a minute, you can do all this, then now they don't want to do work without you because you're making it much better for them. It's much easier. It's much safer for the patient, and the patients are getting better sooner because you're giving them options of how, because we have a supply chain issue. So we can also, the options of what can actually, if we don't have this drug, how do we use this? Just the other day, I was actually rounding somewhere with some doctors, and they didn't have a pharmacist on board. And one of the things they said was, sometimes I write a drug and I don't even know whether the patient got it. I was like, And then they also went ahead and told me, sometimes I will actually dose a medication. I don't even know how to dose it, and I can't find a pharmacist because we don't have a pharmacist to dose it. So I dose it as best I can. I have a friend who lost her hearing because of there are some medications that if you don't monitor properly, you either lose your hearing or they call aminoglycosides. You either lose your hearing or your kidneys. And the fact that it wasn't monitored, they lost their hearing.
Wow.
That's pretty extreme.
Oh,
Wow.
Well,
But also, I'm not saying, I'm sorry, I'm
Go
not
ahead.
saying that it's extreme that, don't bring it in. I'm saying that it is so extreme not to want to have this inclusivity that we speak of for then pharmacists.
yes. And I think the issue is also, now, the issue here now comes, which is a thing that we have to really think about as a country too. It's delayed gratification. Sometimes we talk about how much do we pay now. What you pay now is already paid. But what is the investment you've just done? If you pay a pharmacist 200,000 and they save somebody's life down the line, or they save the healthcare system, the way it's using its products, right? That is a community benefit that sometimes we don't look at. We look at how much are we paying somebody now? What is coming out of my pocket now, and not what am I investing in terms of the benefits that will come down the line. And I think this is the thing we have to really think seriously about. I have dealt with patients' records that I look at and I cringe. I cringe at how bad they are. And it's reality, it's there.
I look at regulation of our healthcare system. So you are regulated by the Pharmacy and Poisons Board presently, right? Which is now going to be the Kenya Drugs Authority if it passes through Parliament. That is separate from who is regulating the doctors and hospitals. Even to operate a hospital, it's the KMPDC that will allow the hospital to run. But within that hospital, if there's a pharmacy, it's a Pharmacy and Poisons Board
Correct.
that will allow the pharmacy to run in the hospital.
Correct.
And then you've got nurses who have the nursing council.
Correct.
And everybody is just being regulated by everybody else.
Correct.
And it appears like these bodies are ending up not talking together, despite even the establishment and the existence of the Kenya Health Professions Oversight Authority. What does it do, and how does it bring that conversation together? And then you as healthcare professionals have also come together in the various associations, Pharmacy Association, Doctors Association, nurses. You also have the Healthcare Federation, where you all come together. It appears you have opportunities to say the same thing, but you don't. Why?
Interesting. I don't know whether I have the age or to answer that, because by the way, the issue of having different...
As CEO
Yes.
of the Pharmaceutical Society of Kenya, you represented your people.
Correct, yes.
In the Kenya Healthcare Federation.
Yes, I did.
All right?
Yes.
Why are you taking these concerns to the Kenya Healthcare Federation to say, all right, people, can we think of how we can reorganize this system so that we all are serving this patient end to end?
We had several conversations, and the conversations sometimes were as a result of quote-unquote encroachment, where somebody came and did something in another area's jurisdiction, blah, blah. But you see, international standards is the same way. I mean, if you go to other places, the UK, the US, the pharmacists are run by a pharmacy board somewhere, and then the nurses on their own, because of the speciality of what they're doing.
Okay.
But I think one of the things why it works better there and why they actually include, I know that in the US, it was liability. There's something called standard of care. So when a patient passes away in a hospital, they say, okay, what did they come in with? This and that. What is the standard of care? The standard of care includes consulting a pharmacist on medications that you gave. So that the liability folks will look and say, did you do that? No. Then you're automatically liable, whatever the case might be. If you followed the standard of care, then now we can discuss and see maybe mistakes happen. But the key